Right, good afternoon, everybody. Welcome to our Greater Manchester New Roles ARRS Employee Webinar Series. It's great to see you all today. Thank you so much for coming. My name's Alison Lee. I'm a GP and Clinical Director for Primary Care Workforce for Greater Manchester. Whilst everybody is still joining the call, please can the organising team say hello, please. Natasha?
Hi everybody, I'm Natasha Odita. I'm a Primary Care Workforce Programme Manager at the Partnership.
Thanks, Natasha. Rob?
Hi, I'm Rob. I am a Project Administrator at the Greater Manchester Training Hub.
And Liam?
Good afternoon, I'm Liam Genyon. I'm responsible for the comms and media, the Greater Manchester Training Hub.
Thank you. And this afternoon is brought to you together by the Greater Manchester Primary Care team, the Greater Manchester Training Hub, and our Health Education England Primary Care Ambassadors. The topics for this afternoon are the new roles. We've got a speaker on dietitians. We've got our OT colleagues, podiatrists, and also we've got a further update on first contact practice by Amanda Hensman-Cook. As some of you may have heard earlier on in the call today, it would be great if we could keep the chat box live. What I'd really like to hear from you this afternoon is your questions for us today. So what are you wanting this webinar today to answer? And have you got any questions that you'd like to pose to any of the team? Rob, Liam, myself and Natasha will be monitoring the chat box throughout the meeting. Well, we've got 3 speakers, and after each speaker we've got an opportunity for Q&A. So please keep the questions coming, the feedback in the chat box, and I think we can kick off then. So please can I introduce Tanya to talk about dietitians. Thanks so much.
Just to start off, as a reminder, what does the DES say about dietitian roles in primary care? They're at a band 7 level, so that's a Agenda for Change indicative band 7. This means that they are very experienced dietitians. They need to have undertaken a postgraduate or undergraduate degree in dietetics and a training programme approved by the British Dietetic Association. So the BDA is the professional body for dietitians, but not all dietitians have to be part of the BDA. However, most dietitians are, because this is where we get our professional indemnity insurance from. So it's just one thing to consider if you're employing people, that they don't actually have to be part of the BDA, but most dietitians will be. They do have to be a registered member of HCPC, so this is the regulatory body. And the DES recommends that they need to be able to operate at an advanced level of clinical practice. So this is level 7 in the 4 pillars of advanced practice. They need to have access to appropriate clinical supervision and an appropriate named individual in the PCN to provide general advice and support on a day-to-day basis. So just going back to that bit where it says about the clinical practice. So what this really means is that it's trying to look at whether, if you're looking at interviewing or shortlisting people, you're looking for evidence that they have undertaken some advanced clinical practice roles or some non-medical prescribing training. And this is really to make sure that you get people at the right level of practice. It might not be suitable for dietitians as a first job going into, as their first band 7 job going into these roles. So ideally, when you're looking at recruiting into these roles, they would have already been practicing at band 7 level or equivalent. It's important to remember that the bands are only relevant to NHS practice, and obviously we do have dietitians working in private practice. So it's looking for that idea that they've already worked at an advanced level. So dietitians have been eligible to register for non-medical prescribing courses since 2016, but not that many dietitians have undertaken the course at the moment. So if this is important for you in your practice, it's important to remember that you might have to support a dietitian to undertake this course, or you need to put it as essential or desirable on the job description. Historically, NHS dietitians are employed in acute or community trusts. Dietitians working in primary care is an emerging role. So although there may be some dietitians working in primary care settings, it's usually at a lower grade of practice, not at this advanced level of clinical practice that the DES is looking for. So because dietitians mainly work in secondary care and acute, what that means is that sometimes the local dietetic services can feel a bit remote to GPs, and it can give the impression that there's potentially not much out there. So it's important, therefore, before you recruit, to try and get an idea about what your local nutrition and dietetic service provides. And this is mainly just to avoid duplication. So, for example, there might be a lot of dietetic services working closely with care homes. So they might be providing training and allowing direct referrals into the dietitians that the GPs might not necessarily be aware of. So even if you decide to recruit directly into your PCN rather than through your local provider, it's still worth making contact with them to find out what you already have in place to make sure that we are avoiding duplication. So I'm just going to talk about first contact practitioner versus dietetic-led models. I'm not sure how familiar people are with the FCP model, so I just wanted to define this in terms of how it relates to dietetic practice. So obviously FCP means you're the first clinician to see that person on presentation of a new condition. So all GPs are working as FCPs. But as we've already discussed, most dietitians work in community or acute. So that means that any patients they are currently seeing would likely have been referred to them by somebody else. So they might have had patients referred by GPs, health visitors, etc. So most dietitians won't be working at the moment in first contact roles. So as this definition suggests there, and this is taken from the HEE Paramedic Roadmap document, FCP means working at the top of your clinical scope of practice, and you're assessing and diagnosing undifferentiated and undiagnosed conditions. So this is also why I've said that potentially these PCN dietitian roles may not be suitable for somebody coming into their first Band 7 role. You might want somebody who's already worked at that level for a bit of time. A dietetic-led model is a little bit different. So what this means is that potentially they're not the first point of contact, but they're potentially taking over a lot of the pathway that historically would have been managed by GPs or nurse practitioners, etc. So this is potentially where a dietitian sat within a PCN is seen by a GP, a patient is seen by a GP to start off with, and then they're referred onto a dietitian that can manage the rest of that patient's journey. So dietitians absolutely have the capability to work in FCP roles in primary care, but at present the framework to support this role is currently in development, so it's not there yet. So Health Education England is hoping that this will be ready for publication in the summer, and it will be very similar to the Paramedic Roadmap. So for those of you who haven't seen the Paramedic Roadmap, I've put a link to it at the end of this presentation. The dietitian one will look very similar to that. So what this sets out is the additional training and clinical supervision that dietitians will need to undertake in order to work as first contact. But the reason why I've put in there about the dietetic-led models is because in the meantime, even if not in FCP roles, we can set up these pathways to take on a lot of that additional work that is currently being undertaken by GPs. So there are 5 clinical areas that the professional body are supporting dietitians to lead on, which are shown here. So the top 4 are adult pathways, and then the 5th is infant feeding, so including cow's milk protein allergy. What I've highlighted on here is that most dietitians at this Band 7 level work in either adults or pediatrics. It's very rare to get somebody who is working at that level that can cover both. So if you're looking to recruit to these posts, it may be that you need to think about potentially recruiting to 2 dietitians. So it might be that you're looking at recruiting 70% adult dietetics, 30% pediatric dietetics, or another reason why is potentially to work with your local nutrition and dietetic service provider to see whether you can get a combination of both. In the future, it is likely that we will see more dietitians following a career pathway that allows them to work at this level in both adults and peds. But as a profession, that's rare at the moment. We're not there yet. So to put all of this into context, I was going to talk through some examples of how this might work in practice, explaining a couple of common conditions and how this could work at an FCP or a dietetic-led model example. So if we take a common condition, for example, gastroenterology, such as IBS, what the data shows us is that patients with undiagnosed IBS see GPs 10 times more frequently than matched patients. We know that 1 in 12 GP consultations are for gastro symptoms and that 46% of these go on to be diagnosed as IBS. We also know that dietetic advice can reduce symptoms for IBS patients in 70% of them. And therefore, it does make sense that potentially IBS is an area that dietitians can really add value to. So if we look at a typical IBS pathway, if we didn't have a PCN dietitian in post, so if we had our local community or acute dietetic provider, everything in the red box is what we would potentially ask a GP to do. Everything in a green box is what the dietitian does. So at the moment, your traditional IBS pathways might look a little bit like this, where the GPs are assessing for red flags, they're taking a history, ordering some investigations, potentially some bloods, some screening tests. They potentially are providing first-line dietary advice, providing first-line pharmacology advice, and then potentially referring on to a dietitian in secondary or community services if they need more specialist dietary advice, so for example, a low FODMAP diet. So looking at this one, as I said, everything in a red box is GP, everything in a green box is dietitian. What you can see that if you have a dietitian in post working as a first contact practitioner, potentially all of this can be managed by a dietitian. So from the point at which a patient presents with potentially new onset diarrhea, abdominal pain, bloating, those sorts of symptoms, they can be booked in to see a first contact practitioner dietitian who can assess for the red flags, take history, order any investigations that need doing, provide the first line dietary advice. If they're a non-medical prescriber, then they can also look at prescribing pharmacology interventions. They could then, if that's within their skill set, they might be able to provide advice like a low FODMAP diet, so specialist dietary interventions, or if they've got really good pathways with their local providers, they would refer on. But then the patient would come back to them for them to be able to see whether or not those interventions have helped. So the difference between the previous slide and this one is obviously that the vast majority of the last slide was undertaken by a GP, but with a first contact practitioner dietitian, there's no reason why that couldn't all be done by a dietitian. So another example is cow's milk protein allergy. So again, everything in a red box is a GP, everything in a green box is dietitian. So traditionally, our pathways without a PCN dietitian might look like this, where the GP is assessing for red flags, potentially suspecting cow's milk protein allergy. There need to be taken an allergy history from parents about the child. They'll be advising on dairy-free trial if the patient is breastfed. They might be prescribing a suitable first-line infant formula. And again, they're doing an awful lot of steps before they refer on to a dietitian who is potentially only providing weaning advice. If we move on to the next slide, we can see how that might look different with the PCN dietitian in post. So going back to the FCP versus dietetic-led model, in this one with it being children, it's more appropriate that a GP potentially assesses that bit for red flags. So they might be the first person to see that child, but then the rest of it can be managed by a dietitian. So the dietitian is taking on the allergy history, the trial of the dairy reintroduction, a cow's milk protein allergy diagnostic trial. They're prescribing the first line product, moving on to the second line product if they need to, and providing the weaning advice at the time that when it's most appropriate. And this sort of stuff can also help with prescribing and making sure that we don't overprescribe infant formulas. So as I've mentioned already, the dietetic roadmap from FCP to ACP is in development. And once this is published, it will be a lot clearer in terms of what these roles can offer and the training and support that needs to go along with them. The Advanced Practice Primary Care Credentials is also in development, and it is likely to be published around the same time in summer this year, 2021. So just talking a little bit about training requirements for these dietitians. As I previously mentioned, dietitians in primary care is an emerging role, therefore they will need orientation and clinical supervision. But if you employ a dietitian at the right level of competence, they will be working autonomously from a dietetic point of view. Therefore, the supervision should be within the practice to ensure patient and practitioner safety, and it will be focusing more on the core capabilities rather than the dietetics. So it will be focusing on things like prescribing support or clinical examination and diagnostic support rather than focusing on the dietetics. That said, it would still be really good that if that person is employed directly by the PCN, they do link in with their local nutrition and dietetic provider, because that will be important to ensure that you've got good, robust pathways and keeping that relationship open so that you're avoiding duplication. So next steps, if you are thinking about employing a dietitian, then you can get in touch with me. I don't mind having individual conversations with PCNs. I would encourage you to, if you haven't already, engage with your local nutrition dietetic provider. If you don't know who that is, I can put you in contact with the dietetic manager so you can have that conversation. I would strongly recommend that there's a dietitian on the selection and interview panel, again, to make sure that you get a dietitian at that right level of practice to support you in the development of this role. Yeah, so that's just some references. I referred to the first contact practitioner roadmap for the paramedics. The dietitian one will look very similar. And then a little bit of information about the dietetic-led clinics in primary care. The final slide is just really for dietitians rather than this group here. This presentation is going on the BDA's website, so that is just a place that dietitians can get more information about these PCN dietetic roles. Thank you very much for listening. I'm happy to answer any questions.
Thanks, Tanya. Can I just ask then, thanks very much for that presentation. Have we got any questions from the floor or from the team for Tanya? No questions so far, Tanya. What usually happens in these webinars is at the end we often get a flurry of questions, but one observation from me is that the scope of practice for dietitians actually is a lot wider than I had imagined. So managing patient pathways from beginning to end actually does contribute quite markedly to meeting the needs of patients contacting their general practice for quite a range of conditions. So that kind of was my initial reflection from your presentation, and that was the scope of practice. Does anybody else want to share or raise anything?
Thank you, because I just wanted to add to that, if that's okay, that that's what I was trying to demonstrate in this presentation, because I've had a lot of conversations with local PCNs, and some of the stuff that they're asking of their dietitians are potentially things like weight management groups or diabetes essentials group education. And this is stuff that is already out there and is already provided somewhere. And the idea of these ARRS roles is obviously to look at what burden we can take off the GPs. So it's about trying to manage as much of those pathways as we can. So it is trying to open up the ideas of the fact that dietitians can do more than just those things that we historically think that dietitians can offer.
Yes, absolutely. That is the key thing for the whole primary care network ARRS programs is to increase the capacity within general practice and primary care network teams, and not shift capacity from areas that we already have that. So to be honest, that was absolutely well demonstrated. We've got a couple of things on the chat coming through then. First one is about prescribing if you're an advanced practitioner dietitian. Can you share a bit of information about that?
Yes, so dietitians are eligible to undertake the non-medical prescribing course. At the moment, dietitians can only be supplementary prescribers. So I don't know if GPs are aware of the difference between supplementary prescribing and independent prescribing. Basically, supplementary prescribing means that you work within a clinical management plan. So this is an outline that guides the that is a tri-party relationship between the patient, the GP, and the dietitian. So you have a conversation with the GP to say, are you happy that I prescribe these medications for this patient, and then if the GP signs it, the dietitian signs it, and then the dietitian can manage the prescribing of those drugs for that condition. The reason they're only supplementary prescribers is because they are new to it. So from 2016, they've been able to prescribe, and this is generally what happens is the professions are supplementary prescribers for a short period of time. They demonstrate that they're safe to work in that way, and then independent prescribing kind of follows suit. But the clinical management plans are run by the dietitians, and then it's a way of the GPs getting confidence that the dietitians are able to manage those conditions. So I don't see it as being a bad thing, really.
And there's another question, thanks Tanya, there's another question on the chat from Rao, who's saying, how can we sort out non-organic causes from organic causes of symptoms? And I think what you've said from your presentation, Tanya, is actually you can do that first contact assessment, figure out whether there is a organic cause or whether it is a functional cause or an allergy, and that in that way therefore doesn't come back to the GP, so to speak, unless there's an element of uncertainty or something doesn't quite fit. Is that about right?
Absolutely. So this is where, I mean, obviously you need to have algorithms as to what patients are appropriate to come to the dietitian first. That's really important to do that. But in terms of clinical examination and diagnostics, this is all part of the first contact training, first contact practitioner training, that dietitians are able to take on those elements of the role. So if a patient presented and a GP would normally do an abdominal examination, for instance, then the dietitian trains to be able to do that part of the role as well. Obviously, we would follow things like NICE guidance. So NICE guidance lays out when you should, when you shouldn't investigate, and the dietitians can refer on for endoscopy or for other procedures that need to, but that would be following a consultation or a discussion with a GP to make sure that that's an appropriate route for that patient, and taking histories as well. So that is something that is part of dietitians training at advanced practice, is to take a thorough history for these people.
Thanks, Tanya. And I've got a separate question then. I'm just going to ask a really daft question, and that's around engaging a dietitian at a advanced level. Through the ARRS scheme, can you engage a dietitian at a less advanced level, or a non-first contact level, or non-advanced level?
So at the moment, the ARRS doesn't specify that they need to be first contact practitioners. So the DES at the moment specifies that it needs to be band 7 level, that they're working at advanced level of clinical practice. So if we think about the advanced practitioner, it's across the 4 pillars, and the clinical practice level 7. So an FCP at band 7, it's very confusing, isn't it, the levels and the bands. So they'll be at the same level of practice, level 7, on the clinical pillar. But to be an advanced practitioner, which is indicative grade 8A, you'd be at level 7 across all 4 pillars. So that's leadership and management, education and research, and clinical practice. So these dietitians are band 7. They're not advanced practitioners, but they're working at advanced level of clinical practice.
Okay. And how many of our dietitians that are working in primary care at the moment are working at an FCP level or would meet the requirements of the current FCP program?
So at the moment, when we talk about FCP, very few, because obviously the framework, the document, that's not been released yet. So this is almost a future aspiration, that this is where potentially the dietitians are moving towards over the next few months. So if at the moment, if you were to employ a dietitian, they'd need to be at band 7 level. They'd need to be demonstrating how they're working at an advanced clinical level of practice, so that they've done a postgraduate qualification in non-medical prescribing, or potentially they've done clinical examination, diagnostics, that sort of thing. And they'll be going into a band 7 dietetic role. These roles will progress into FCP as the framework develops over the next kind of 6 months, if that makes sense.
Thanks, Tanya. That's really great. The we're in kind of early stages of implementing the first contact practitioner role, so it's really useful to hear where dietitians are on that pathway. Our next speaker then is Payal, and Payal's going to share her work as a OT, occupational therapist.
Hi everyone, thank you so much for inviting me to speak today. My name is Payal Wilson, and I am a community advanced practitioner within the North Manchester Crisis Response Team, but my professional background is as an occupational therapist. And I've been qualified for 20 years as an OT and primarily worked within a background of stroke and neuro rehabilitation with adults and elderly patients. I'm really, really grateful to be able to be given this opportunity to talk today, because I think that occupational therapists are quite an undervalued resource, really. I don't think a lot of people really understand, and we're a bit late to the game, as we kind of normally are, in that we've been added to the list that can be considered as part of the ARRS roles, and that for us is a really, really good thing. And I hope that this presentation kind of demonstrates the value that OTs can bring to primary care. So the overview of this presentation will be, firstly, just to talk about actually occupational therapy. What is it? Because there are lots of confusing, conflicting views on what OT is. OT in primary care, which is very, very new, talking about the clinical benefits that occupational therapists can bring. And then I don't know whether I'm going to do this now or we're going to have some question and answers and go on to crisis response and talking about the advanced practice offer, so advanced clinical practitioner roles which OTs can also sit within. And as I go along, I will try and intersperse some case studies, because unlike Tanya and her wonderful presentation, we don't have a huge amount of evidence or figures to support OTs working in FCP roles, unfortunately. So it's kind of very, very evolving. So I'm hoping that this can just kind of start the ball rolling and thinking about, you know, if people are thinking about having OTs employed within primary care. So occupational who, and I've put that purposely because I think as an occupational therapist, I don't think we're particularly brilliant at really explaining what we do. And I think that sometimes confusion around the roles comes from the fact that we do work across a lot of different areas and we work in very, very distinct roles. So an OT working in learning disability is completely different from an OT working in stroke rehab. And I know that that can be said with other professions, but I think the core skills that we bring are adapted in a slightly different way. We've been called all sorts. I've been called, you know, we still get basket weaving jokes. We still get occupational health. People don't really understand the difference sometimes between OT and physio, and some professions really do. So I hope I'm not tarring everyone with the same brush. But a definition of OT, it provides practical support to empower people to facilitate recovery and overcome barriers, preventing them from doing the activities or occupations that matter to them. So it's very wordy. That's another problem. And I think the main thing, and I hope that if you take anything from this presentation, it will be that occupational therapy focuses on how physical and mental health dysfunction affects a person's everyday occupations and meaningful occupations that, you know, that they need to do to fulfill their roles, whatever that is. So it talks about the impact of physical or mental health dysfunction on everyday life. OT core skills. So this is the bragging bit. We are the only allied healthcare professionals who have pre-registration training in both physical and mental health. We are able to analyse occupations, like I said earlier, and enable people to be as independent as possible, which, given our current climate of people living a lot longer, people living with lots of comorbidities, being able to enable that independence and kind of take away that dependence on long-term care and the social care sector, it's really, really important. And also for the patients themselves, obviously, most importantly. And looking at how physical and mental health dysfunction affects occupation, I've said that, and proposing solutions to either maintain or increase occupational performance. OTs are also, but we're very primarily positioned to think about personalised care, particularly because we take kind of that very holistic approach in terms of assessing a patient's functional independence. So When I was thinking about putting this presentation together, I kind of was thinking about the OTs within our team. And even though we are not working within primary care networks, and I have to stress the fact that I did tell Natasha when I was preparing this, I was like, I'm not really working in a PCN. We do work very closely with our GP colleagues. And so when I'm thinking of the referrals that come through for an OT perspective, it tends to be those patients who, they seem a bit off their feet, or the carers are really concerned that they seem a bit more confused than normal. So the GPs are obviously in this case looking at the medical reasons why that may be, but sometimes the GPs will refer to us to look at the other social factors or environmental equipment barriers that are stopping that person from maximising their functional independence. So functional assessment tends to look at things like personal care and domestic tasks. So how can that person attend to their personal care? Can they get washed and dressed? Do they need some equipment to help them do it? Do they need carers to support them in doing that? And what are the actual barriers to enabling them to maximise their independence? Mobility and transfers tend to be quite a common one. Well, they are just a bit off their feet, and it's kind of like working out exactly what the reasons for that are. Is it because they're struggling to weight bear? Is it because they've got limited range of movement? Is it because of pain? Is it because of the height of furniture in the house? So it's really looking at the different things that could be causing detriment with that. And then falls assessment. So we get a lot of referrals through from GPs for patients who've had falls and who we can then go and assess them in terms of their range of movement, their power, but also to provide solutions in terms of both educational, but also from an equipment perspective, and risk assess around reducing that risk of falls as we go forward. I think cognitive assessments and memory screening is really important, and one of the biggest areas that our occupational therapists will support the GPs within this area is by undertaking assessments of cognition. So that's standardised assessments that may contribute to longer term planning, that may be around ascertaining capacity, it may be around looking at, so we support the GPs with our dementia pathway, so the OTs will conduct two standardised cognitive assessments, so one being the MOCA and one being the mini ACE, and they will then utilise those scores along with the bloods that they use to screen and to rule out infection and other causes that may be impacting on memory, and that then enables the GPs to directly refer into our local memory clinics and to obtain a proper diagnosis for patients for them to access long-term services. I think frailty is a massive area that OTs are really good at picking up on. Obviously, frailty is again the bread and butter of OT. Really, it's looking at how a person's resilience is affected by physical and mental dysfunction, and about how that frailty, as it increases, about really maximising a person's functional independence within that setting. So it's not only assessment and management; it's identifying those at risk of long-term placement because their frailty scores are just going up and up and up. So it's kind of like a real proactive approach to kind of prevent that deterioration. I've put advanced care planning because I think that we are again at a really good position to be able to implement certain things to assist with the advanced care planning. And I think advanced care plans, particularly in North Manchester, we really struggle with getting advanced care planning done in a timely way, particularly when patients have got capacity to make those decisions. So OTs looking at functional independence alongside cognition really have a role to play within that. And also social prescribing. So social prescribing is massively high on the agenda. And again, it's about making sure that you are identifying those various areas of dysfunction and being able to refer on to services that will be able to support a person with that. Vocational rehab, so occupational therapists also work within vocational rehab, so really looking at enabling patients to return to work and looking at the reasons, again, both from a physical and mental health perspective, and learning disabilities. A lot of OTs and learning disabilities will work with patients to try and get them tapped into local charities and vocational rehab courses to get people back to work. And in North Manchester, we have quite a high proportion of back pain. So a lot of patients that are off with back pain, that the OTs work really closely with the GPs to try and formulate plans to get them back to work as soon as possible. And obviously equipment and adaptation. So it's about, we've recently had a really good example where we had a patient who was a faller and the GP said, we've ruled out everything. This lady was a 69-year-old lady with multiple sclerosis. The GP said, we really don't understand why she's falling and also why she's struggling so much at home. So our occupational therapist went out And actually, it was a real light bulb moment, because they did a lot of work closely with her, and they did functional assessment in the kitchen to see exactly what her. So when we do functional assessments, it's not just making a cup of tea. It is just breaking down that task into its various components. So looking at cognition, looking at standing balance, power, motivation, looking at things like cultural ways of making cups of tea. But I think most importantly, it's about breaking that task down and looking at the various things that person needs to be able to do, and identifying the areas where there's a problem. So it could be that they're not able to stand. It could be because they haven't got the higher executive function, so they're not able to sequence the task appropriately, or they've got cognitive difficulties. It could be a visual impairment. And by doing that really basic activity, it allows an OT to really break it down and work out which parts they're struggling with, and then propose solutions. So it may be that they get them a perching stool to sit on so that they're not standing for long periods of time. It could be that we provide equipment like a liquid level indicator for someone who's got visual impairments, so that they know when they've filled the water up to a certain line, and they can make that themselves. With regards to this lady, when she was opening her cupboards, as she opened the cupboard outwards, she was falling. She was losing. She hadn't got really poor dynamic balance, so she was overbalancing and then falling backwards. So through a really good rehab program, we got her in touch with our home care pathway therapist, and she then was able to kind of work on a standing balance, get the various bits of equipment, and she was able to maintain, and that reduced her risk of falls, which was as simple as that. And it was a really good example of the OT kind of role. And our OTs also work within the housing. So it's not just looking at aids and adaptations for housing, because so many of our patients come through and they are limited by their environments. So they will struggle to be able to get out of the house. They're socially isolated because of barriers within the house. But it's also looking at things like in North Manchester, we have a high level of socioeconomic poverty, and we've got a lot of patients who are in housing that isn't appropriate, or that is suboptimal conditions, and that affects their physical health. So we've got a lot of patients with damp. We've got patients who've got lots and lots of different things, and we work with the private landlords and the GPs to try and get those issues rectified, so that that will have more of a positive impact on their physical health.
So does anybody want to raise any questions or engage in a conversation with Payal? You can always use the chat box function as well.
I've got a reflection, if that's okay. So I'm just going to, I suppose, use this opportunity to compare the two roles, our dietitian's role and our OT. The benefit I can see dietitians working with us in general practice are actually our bread and butter first contact work. So if somebody decides they need the help of their general practice, I think there are certain pathways and conditions that our dietitian colleagues can help with. In comparison, from your presentation, Payal, what I thought more was that our primary care network enhanced service specifications around frailty, advanced care planning, and the IIF or the IFF, I can't remember which way around it is, health checks for people living with mental health needs and learning disabilities. I think that's where you come into your own, and I can really see the benefits and advantages for having you in our general practice teams working alongside the rest of us, looking after people with frailty, dementia, advanced care planning. It sounds great, to be honest.
Thanks so much, Dr. Lee. And the other thing I will say is that I think that that particularly with our falls patients as well, our regular fallers, sometimes it is, it's very easy to say, right, from a physical point of view, have you hurt yourself? Are you on anticoagulants? Have you, is there any infection or delirium? And look at the real medical model issues around falls. But I think when you actually look at patients who have fallen, you look at the patterns behind falling, sometimes there are the other areas that the OTs are really skilled in unpicking. And I think that, the GPs definitely feed back to us within our local area, because we do have a high of older patients. We actually have a high level of young grade you know, frailty for people in their 50s and 60s who are having these significant amounts of falls. And I think that the OTs play a really important role in kind of putting things in place early to kind of stop those falls from causing major injury.
Yeah. And the thing with falls is it's a complicated assessment that actually takes quite a bit of time. So I can see one of my patients in my mind that I've been working with, and she's been tumbling every now and again for some time, and we've worked through whether this might be a stroke or ischemic process. We've worked through whether this was something to do with balance and vertigo. We've worked through whether this is something cardiac. And actually, we've probably got to the point of saying it's multifactorial. And the bit that we haven't done is the strength, conditioning, functioning in her own home. And because of the pandemic, I haven't actually seen her in her own home. Yeah. And she tells me she's continued to fall. So medically, I think I've done a good job, but actually for her, she's still falling. So there is an additional aspect of her need that is yet unmet. And I think that's where I think we can work quite well.
And I think the other thing is that in terms of from a GP perspective, a lot of the time, and it is different for different areas, and obviously local populations will have different needs that will then tailor, you know, or dictate what the best people in those ARRS roles are. But I know particularly for North Manchester, from a therapy point of view, the other thing that's really, really important is that that we're not waiting for weeks and weeks for a community rehab referral. We're not waiting for, you know, it's that process of being able to get that assessment quickly and being able to get equipment or get things in place in a timely way to prevent, you know, any further deterioration.
Mm-hmm. So I'm gonna flip it around slightly and ask a different question to Payal and Tanya. What if you were thinking about making the move to primary care and general practice? What kind of things from that team or organisation might you be looking for?
Do you want to go first, Tanya, or do you want me to go first?
You can go first.
Thanks. So I think for me, and probably coming from a really supportive, I think for me, working as an independent practitioner and as an only OT, really, if it was just me within that practice, I think it's about maintaining that clinical supervision and clinical support to make sure that I progress and that keep on top of my own development and learning. So it's about who I go to for supervision when I'm not in an area where there are lots of OTs or there's a hierarchy. So it's making those links. And I think it's also about establishment, because I think for me, from an OT background, I think that, and being an advanced practitioner as an occupational therapist, I think I've had experience in this, is that it's a very new role. And so I think it's about how we then develop that to meet the needs of the population and who I can utilise to help me with doing that.
I mean, I think I would say very similar things, that dietitians haven't historically worked purely in primary care. They've always been part of bigger teams. So potentially they're with 30 or so dietitians. They're with a big cohort of colleagues, and therefore to work in primary care, it's a completely different environment. So they will need that orientation. They will need that, support to be able to get the most out of your dietitian. But actually then, as part of an MDT, it's making sure that you're able to utilise the skills of those that are around you, rather than it being uni professional. So just everybody's got something to bring to that mix. So yeah, for me, it's same as Payal said. It's about that support and making sure that you've got your links to your dietetic colleagues, so that you've got that support still there, but that you've also got the MDT around you in the GP practice.
Thanks, that's great. That's really, really important to hear. So thanks so much. Natasha, I'm very happy that Payal continues to an next bit.
Yeah, I think you should. Yeah, wonderful.
Okay, so I'm just going to, again, this isn't part of the primary care network, but this is an example of the service that I work in, which is called the Crisis Response Service. We're part of Manchester Community Response North, and so I'm one of the services that works very closely with the GPs to try and avoid unnecessary hospital admission. So I'm talking about this more from a generic point of view, but I'll try and pull in the occupational therapy benefits. But I work within this service as an advanced clinical practitioner, or an AMP, ACP, as they're often abbreviated to, but I am an occupational therapist by professional background. Our crisis response service is an urgent community care 72-hour service, so we're short input for patients or people within our communities that have a North Manchester GP but who are in crisis. So we are an integrated health and social care delivery model. So we've got we're integrated with we've got social workers, we've got pharmacists, we have advanced clinical, it's advanced practice led. So we haven't got any medics, no GPs or consultants that work as part of our team. But like I said, we do work very closely with our GPs. And we basically primarily take referrals from the ambulance service and GPs. They're our primary kind of referral rate, more from the ambulance service, but you know, definitely GPs as a close second. But we can take referrals from A&E, and we do have a lot of patients referred to us via the GPs in A&E that work in A&E, or the frailty teams that are working at MRI. And we also have a back pain pathway that clinicians can refer into. So we can take pretty much from any of the community services plus NWAS and GPs. And we basically have a 1 to 2 hour response. We work 7 days a week, and we work, our operating hours are 8:30 in the morning till 10 at night. And after that, we have out of hour, obviously go to doc, take on our out of hour provision. Like I said, we're short input, but we are a multidisciplinary team. So we have OTs, physios, ACPs, pharmacists, social worker, the lot, and it is an integrated model. So we could, because we've got so many different professions working within that team, we are really lucky. We're a credible alternative to A&E. We've been around for 7 years now, and the model has now been so successful. It's been rolled out across Central and South Manchester now. It's just started, and Salford also have their own crisis team, although it's a slightly different model. But what it means is that we have got the capacity to really, really look after our patients in their own homes for those that can be managed. So we've got really good links with the home IV teams, with the community rehab teams, with charities, with care agencies, so we can get overnight sits for patients, we can get, you know, increase in care packages, and we very rarely step up to respite care. We tend to keep patients at home as much as we can. But what it allows me to do as an advanced practitioner is I can take a referral, and so the GPs will refer to me, and I will triage that referral clinically with them. So for example, it may be that the GP has had, particularly in COVID, when GPs haven't been able to go and see the patients, we've worked really closely with them to go into to see that patient, to clinically assess them, to put clinical management plans in place. We can prescribe and de-prescribe. Now, as an occupational therapist, unfortunately, we are still fighting the battle about prescribing, and we are in the process of working with the Royal College to really push that prescribing agenda through, and that it is going to happen. It's just all the kind of hoops we have to jump through to get there. But as a team, we have got prescribers from physio background, from nurses, paramedics who can prescribe, and our job is we are able to go and see patients in their own home. We can do bloods, we get our blood results back in an hour, we can interpret those results, we can commence treatment as necessary, and we see patients from a wide range of backgrounds, from musculoskeletal pain, abdominal issues, we've got lots of chest pain. North Manchester has a very high COPD population, so we get a lot of respiratory exacerbations, and we have got the skill within the team to be able to do a lot of diagnostics, including ECGs, and be able to interpret those and put in management plans. So we work really closely with our GPs. So the advanced practice offer is slightly different in that we can clinically do a lot of the management and monitoring. So we do get a lot of GPs referring to us saying, look, I've started this patient on treatment for a chest infection, but I'm not quite sure how it's going to go. They are very at risk. They're very frail. Can you monitor them over the weekend or for the next few days? And we can go in, we can repeat bloods, we can do all their physiological observations in their own home. We can also refer to our ACU, which is like our acute ambulatory care unit, where we can get patients in for imaging, particularly with suspected DVTs and if we've got PEs, suspected PEs. So that's really, really, really good. Excuse the picture. So this basically is a picture trying to depict the importance that an OT and advanced practitioner can bring to a service. And I think the difference with the OTs being in advanced practice positions is, again, we can go and do that clinical management. So we can go in and we can listen to a patient's chest, we can do all of their physiological observations and we can interpret those accurately, but we can also do the cognitive assessment, refer for equipment and adaptations, look at a person's balance, their power, their function. And so particularly for our falls patients that come through the crisis response team, we follow a falls pathway where all of our patients have to have an advanced practice assessment, they have to have a therapy assessment, and they have to have a pharmacy assessment. So for our ACPs that are AHP by background, so either physio and OT, the physios can do the whole lot because they can do the prescribing and the de-prescribing. But because we have got a pharmacist, it doesn't really put us at a disadvantage. So as OTs, we can do pretty much all of that assessment. So that assessment, it would include a full neurological assessment, cardiovascular and respiratory review, and then looking at power, tone, range of movement, balance and things like that. So it's a really, really important kind of example of how OTs in advanced practice positions can really, really provide that holistic and complete episode of care. So the impact of that, on average, the crisis response team at North Manchester receives between 70 and 80. I think that our average for the last 6 months has been 76 referrals a week. And they are, like I said, a mixture of NWAS and GP referrals. But for the patients that we keep at home and using the local tariffs, that we have saved significant amounts of money by preventing patients from going to hospital. So particularly for our patients who are vulnerable with increased frailty, our dementia patients, for the patients who we've got a high level of health illiteracy and we get a lot of red refusals, so patients who should go to hospital that don't, we can really, really maximise the care that we can provide within their own homes. And that makes a huge, huge difference. So like I said, for the GPs, we are able to kind of work very closely with them in monitoring and managing that care. You know, we can go back in and see a patient at 9 o'clock at night if we've seen them at lunchtime to make sure there's not been any deterioration, to check that their SATs are still within their normal range, to check that they're responding appropriately to the clinical management plans that we've put in place. I'm not going to go through case studies because I think we're just going to be here for a long time, and I appreciate that it is a time constraint, but I'm more than happy to speak to anyone if they do want to look at that model. And I think from an OT point of view, this last slide is a bit cheesy, but it does it really, really has helped me, because as an OT doing a position that isn't really found a lot within occupational therapists, it is about being proud and thinking differently and making an impact. Thank you.
Thanks, Payal, and thanks, Tanya. I think you've both done amazing presentations for which I'm absolutely grateful, and it's really been an eye-opener to look at your professions and scope of practice in a huge amount of depth. I'm very happy for anybody to ask questions at this point. If not, would it be all right if your contacts are shared with our colleagues connected on the call, if they wanted to reach out to you and just ask you a few more questions related to their practice or network or organisation? Is that okay?
Absolutely.
Yeah, that's fine. Thanks
so much. That's great to hear. So welcome, Amanda. Thanks for joining us. I know you've had a busy clinical day today. Really grateful for you jumping on the call. So this is our second New Roles ARRS webinar, and there's just a bit of time again to explain to colleagues who haven't heard it already around the development around FCP and advanced practice in primary care, and really the considerations for providers and employers in that space. Is that okay?
Yeah, that's absolutely fine. And I believe that you focus into OT and dietitians, is that right?
Absolutely, yeah.
Lovely, so I'll focus on that too. Okay, so shall I pull up my presentation? Well, hi everybody, thank you for having me here today. It's Nice to see you. I'm Amanda Hensman-Crook. I am the Health Education Allied Health Professions National Clinical Fellow, and I work in primary care, and I'm responsible for all the new roles moving into primary care for the AHPs in terms of the training pathways, the supervision and the governance around the roles. Okay, so basically what's really important to understand is that for all the AHPs moving into the primary care, it's a standardised training pathway, and it's got the same supervision programme wrapped around it. It's got the same governance, and it aligns with GP training, and it's really deliberate that it aligns with GP training for two reasons. One reason is that the GPs understand the level of practice that we're working at as AHPs, but the other reason is because we are working in primary care, and it would make sense that we're following a similar training pathway to the way that medics train to be GPs, and this it's also a tried and tested route, so it's something that we know works. So I just wanted to talk about what is FCP and what's advanced, because they are different things, and I kind of, if you draw your eyes to the left hand side of the screen where you see an enhanced bubble and an advanced bubble, you'll also see that I've put bandings underneath it, and that's the last time you hear me talking about bandings, because it's just the amount of pay that you take home at the end of the month. But in terms of the additional role scheme, since they're talking about band 7 and band 8As, then just to put it in context for this really. But for the Centre of Advancing Practice, we have enhanced, advanced and consultant level of practice. I didn't put the consultant level on because we haven't done that for primary carers yet. So enhanced level of practice is when you've already been, when you've done your degree and you've moved into the real world and you're registered and you've worked a couple of years, and then you start specialising or you start picking up your craft as time goes on. That's enhanced. And if you imagine like a timeline going across the bubbles, so the left hand side will be when you've just gone from, say, 2 years preceptorship, if you have a preceptorship in your particular profession. So then you're moving in at that side, and then as time goes along, you're picking up extra skill set. You're learning about the patient pathways, you're learning about the multi-professional team, you may be picking up a few masters modules as you go along. And then when you get to the right hand side of that bubble, where the overlink is, that's the point really where the two lap, where for FCP sits. So they're right at the top of enhanced, but they're beginning their advanced pathway journey. So FCPs are working clinically at master's level, and during the process of their training to be FCPs, they've picked up some of the master's level domains across the other 3 pillars of practice, but they haven't quite done that yet. But as you see, if you carry on a timeline across the advanced pathway, they're coming in at the entry point of advanced, and then you're moving along the advanced pathway as a training pathway to become an advanced practitioner. So what's an advanced practitioner? So they're working at master's level in their clinical, education, research and leadership pillar of practice. Basically, the training pathway is the same for all of us AHPs. We get our pre-registration degree, and it doesn't matter whether we come out with a degree or a master's degree, or even if you're really super duper clever, you come out with a PhD. The point you enter into the workplace, you're a novice practitioner. Now, this is because you haven't had time yet to apply your knowledge into practice. So everybody starts the same as they come out at this point. So it says a minimum of 3 years on this diagram, because this was the MSK example. So what that means is that if you're an MSK practitioner, if you're a physio, then that means that you're working as specialising in MSK for 3 years before you go into the path, but you'll have done 2 years beforehand doing the rotations before that. So realistically, for all practitioners moving into primary care, you're really looking at starting your primary care training at 5 years post-graduation. And the reason for that is you're working at master's level, and even though academically you might be able to have done a master's degree, like I said, before you even turn up into the world as a registrant, that just proves that academically you're working and thinking at master's level, but it's not about, you haven't yet got the mastery of applying that academic knowledge into practice. So roughly around 5 years, and you've been working in your field and developing your superpowers as time goes on. That's the point where you do your primary care training. 2 ways of doing it. You've got a portfolio route or a taught route. The domains and the knowledge, skills and attributes documentation and stage 1 and stage 2 in the roadmaps are exactly the same whether you do portfolio route or a taught route. It sits within the taught route exactly the same, and all of the domains are marked to master's level of practice. So stage 1 in the portfolio route is that proof of academic knowledge. So you're signed off against all of the domains by your supervisor, who's specific to this pathway, who's trained as a supervisor. I'll mention that later. And they sign you off as working at master's level academically, and then at stage 2 you move into primary care and you apply that academic knowledge into practice, and you're signed off by a supervisor using the work-based place assessment toolkit, which is exactly the same as the GPs do, which is a little bit different and a little bit left field for us AHPs in terms of a supervision programme, because it's kind of like an educational, it's an educational supervision, because you're being verified and signed off as working at that level of practice. Then once you're signed off as an FCP, you get put onto the FCP directory, and then you've got the opportunity to continue along the knowledge, skills and attributes document, which is a top up for advanced practice, which completes the other 3 pillars of practice. So the new roles in primary care, we've got paramedics, dietitians, occupational therapists, podiatry and MSK. So you may or may not know that the physiotherapy roadmap to practice landed in October and the paramedics landed last month. So these are the timelines for everybody else. So podiatry, we were planning for late February, but because we've had a bit of a change around with COVID and with the way that things are going with the vaccination programme, we've actually got a pause on all comms at the moment, Health Education England, for this month, just around COVID comms. So that will actually land in March, the podiatry. And we're still aiming for the dietitians and the OTs roadmaps to be landed before the end of June, but hopefully in the early spring. They are done. They're all being worked on at the moment. It's not that they're not there. It's just that it's really important to land these roadmaps as a step approach. So we need to land it, period of embedding, sort out any teething problems, and then the next one. And what it does do as well is it allows us to focus on each profession as we go along, so that you're showcasing your superpowers, so that primary care really understand what benefit you bring to primary care. So I mentioned the supervision. So it is really different. I don't know if any of you have done the supervision course, the 2-day supervision course out there. So anybody who holds a full postgraduate master's degree, or if you're a consultant practitioner, or if you're a GP or GP trainer, you can all do the supervisor's course. It's a 2-day course, and both days have to be completed to be recognised as a supervisor and put on the Health Education England supervisors directory. So it's the day one's about what is supervision, unpeeling that onion, because it means a lot of things to a lot of people, and it's also about understanding the roadmaps, because this is multi-professional supervision. So even though we've pump primed the physios, that was because there were no supervisors on the ground, so we needed to make sure they were there when we landed the roadmap. We've pump primed the paramedics, and we've got our regional sentinel trainers being trained this month, and then we've got 2 more cohorts. There will be 70 recognised national trainers who will be a pool of trainers for the training hubs to be able to use to be able to put out the supervisor courses. So watch this space. Anytime from March we should be starting to get supervisor courses coming out from the training hubs for you to attend if you want to be a supervisor. Day 2 is really the key day about learning how to use the work-based place assessment toolkit. It is really different to what we've used before, but it's also transformational in terms of how we look at supervision in terms of a supporting tool. And it's as you will see as you go through the portfolio route, or if you decide to become a supervisor, and we would encourage all AHPs to become supervisors and link in with their local HEIs to help support the taught route, so that there's some clinical placements for these guys to go on. Before we go, I just wanted to talk about the OTs and dietitians specifically, because I'm talking about the superpowers and what we know in the roadmap they're going to be really focusing on. So with the knowledge, skills and attributes document at the bottom, there'll be specific presentations that will be looked at for dietitians and OTs. And for OT, the 3 main areas of practice that will be looked at is mental health, older adults and vocational support. Okay, so it's really important to have that broad base. And for dietitians, it's going to be diabetes, weight management, functional bowel disorders and celiac disease and frailty. So they're the ones that are really broad, and that matches the credential, the primary care credential for advanced practice that's being developed in primary care at the moment with Skills for Health. So any questions? I'm happy to take them.
We've got a question in the chat, Amanda.
Okay, our supervisors funded at, our supervisors funded at all for their supervision assessment time. Well, I'm going to do it in bits if that's more, because I forget what the first part of the question is normally. So the supervisors are not funded, the trainers are funded to run supervisor courses. Now, anybody who's working at this level of practice, at master's level, should have it in their, well, everybody actually, to be honest, should have it in their job plan to have time for supervision, for them to be supervised and to allow them to be able to supervise others. Particularly APs, it should definitely be in their job plan to be able to supervise multi-professionally as part of their role. So no, supervisors are not paid to do this. It should be good practice that we're supervising as the most basic form of governance and patient safety. So GP practices are paid training grants to train junior doctors, which allows them to block out designated time to do. This is not something that's going to be done for AHPs. We're not going to be paying supervisors to do something that should be in our job plans. Ali.
So, noting this is being recorded, yes. here are my current views. I think we are in a developing culture of supervising our multi-professional colleagues, and with my GM training hub hat on, we're working on a series of GP ready programs that support our new colleagues to work effectively and safely in general practice, with a package of peer support, mentorship and structured learning and supervision. Now, within that, we are considering a supervision payment. However, there is nothing nationally coming through for that, but that is what we are choosing to do locally as a GM primary care team and the GM training hub. The second bit that I wanted to share is that actually supervision takes on two forms. The first is the day-to-day clinical supervision of where our colleague is working, and you might need help with, I just need to debrief about this patient I've seen and make sure I've done the right thing. And then there's a second layer of supervision with our new roles and our ARRS colleague, and that is the professional supervision. And that's why I asked Payal that question about what would you be looking for within a general practice or primary care network. And it is the connection to your own professional group to continue your professional development, and as a economy in general practice and as an economy in GM, we need to work through what that looks like and how we support our new roles coming into general practice and meet and maintain their professional development. So I recognise it's critical. I recognise it's critical to patient safety. The CQC recognise it's critical to safety. And actually, if we do want to support a multi-professional general practice, we do have to work out how we do this effectively and meaningfully with those two different roles in mind. Amanda, you had your hand up.
I did. I was being polite for change. You'll be pleased to hear, Ali. So no, that's absolutely brilliant. That's music to my ears that you're putting a strategy in place for that. But what I need to make it really clear about the supervision that I'm talking about is a supervision that's required to pull somebody through the portfolio route. So the two-day supervision course is very different to the everyday day-to-day clinical supervision, because it's a supervision and verification and sign-off process. So what Ali's talking about is making sure that there's a wraparound supervision for day-to-day once you are trained and signed off as an FCP. So the supervision course that I'm talking about is something slightly different. But it is super important when you are looking at job plans that you are looking at time where you're not 100% clinical. Nobody should be 100% clinical apart from getting burnt out. It's really important for patient safety that is factored into the job plan, and we would recommend no less than an 80-20 split, like you would with an apprenticeship route, say. And I think that's really good practice, and it will really grow and make sure we support everybody moving into primary care properly and guarantee our patients' safety.
Thanks so much, Amanda. Any final thoughts or reflections from Payal or Tanya? Anything you want to add that you think you've heard or would like to?
I think it was just very interesting to kind of, from what Amanda said, because it's really, I didn't realise that there was that much information already. I know that the Royal College of OT have been very involved in some of the work around first contact practitioners. I know the physios are way ahead in a lot of ways, so it was just very useful, and it's brilliant to hear the stuff about supervision, so makes me very happy too.
Ali, while we're on the subject of advanced practice, I know that Sonia Kitchen is on the call, and I know that she's got some information about funding for advanced practitioners.
Thank you,
Over
Natasha.
to you, Sonia.
Yeah, I didn't want to gate crash your party. I've been enjoying the session though. It's been really good. Thank you. Yeah, I just wanted to mention, because advanced practice has come up, that the funding application process for HEE advanced practice is open for 21-22. There has been lots of comms already that have gone out, and like Natasha said, it does attract some salary support, and it also supports the apprenticeship and the master's programme route. There are some documents. I haven't got my little attach button, Natasha, but if you wanted to post those into the chat box, there's a funding principles guide and a letter that takes you to a link where you can fill out the expression of interest form. The application process runs until the 15th of March. And I'll put our GM inbox address in the chat box, so if anyone wants to contact me to ask anything, you can drop me an email. Thank you.
Thanks, Sonia. That was very brief. But thank you for the information, and as Sonia said, I'll share that. I'll drop it into the chat box for everybody. Over to you, Ali. You're on mute.
So thanks everybody. Thanks for joining today. I'm just going to close the session by saying thanks to Payal, thanks to Tanya, and thanks for Amanda for joining us from the Lakes, and thanks Sonia very much for sharing the funding notice around advanced practice, because it's always very popular and well attracted by primary care. I also want to say thank you to Natasha, to Rob and Liam for helping produce this webinar today. Our next webinar is due out shortly on the 23rd of February at 4 p.m. And as always, as a good educational team, we very much welcome feedback. Our series is iterative and being tweaked as we go along. So if you could spare us a few minutes by filling in the evaluation, we would be exceptionally grateful. So on the 23rd of February, we'll be welcoming our social link prescribers, our health coaches and care coordinators. Thanks to you all for joining us today. Thank you.